Right, this is we're coming to the end of the day. It's been a very, very interesting day, hasn't it, really? And it's for an open session, really, for questions to the panel. So has anyone got any questions? And please remember to tell us who you are. So no one immediately. Oh, sorry. Thank you. Someone here on the left.
Hi, I'm Stuart Burney from North Tees and Hartlepool FT. It's more of an observation during the day. I think what we've seen for all of us that work in the England healthcare market is the complete and utter lack of integration that we have in our services compared to virtually everything we've heard from everyone outside England today. And it's really just from the panel's point of view, what do you think are the solutions? Other than major changes in government policy, how can we actually go about working more collaboratively?
Santiago, you've got 10 minutes. Go for it.
Well, I think that there is a number of challenges, and as in many other things, one size does not fit all. So I think that solutions may vary from system to system, even within England. The systems may be very different. But I think that it is very important to find the right incentives for people to actually shift. I mean, why I am a GP, why should I change if I'm doing fine the way I am? I'm being paid on a capitated. If I have problems, I can refer patients to the hospital, no problems. Me as a hospital, why change if the more I do, the more money I get? Why, if I'm a mental health trust, why change? I mean, it's about identifying the drivers for change and and to put in place the right incentives for those providers to actually go towards a more integrated system. Definitely, the payment mechanisms can be an enabler. Definitely having a fully integrated electronic medical record. Whether if you keep Systems 1 or MSIS working, but something in the hospitals that can integrate and interface with the information systems running in primary care. I think that having potentially the ability of one entity or someone holding a single budget and allocating resources accordingly, and having all the providers coming together towards what's best for the citizen. So there are some mechanisms that could really be put in place, but if providers are really willing to change, it's going to be very complicated. It has to be a cultural change and a decision of providers to actually change.
Okay, John, you wanted to?
Yeah, well, I can only support this and add to it that as long as the care providers are paid separately, they're only going to do their own thing instead of coordinating. So I fully agree with that addition.
Right, thank you very much. Any other questions?
Yes. It's working, yes. So Jean Miro from Quebec, I have a question for you. So what is the main incentive for the population to change their behavior? I understand for a doctor perspective, but for the population, what are the main incentives to change their own behavior? They don't pay for the service.
They don't.
So what's the interest for them? To do activities, reduce their weight, and I compare with the States where there's some incentive for them. So what in your system they are the incentive to change their own behavior? The patient, from the patient perspective, what are the main incentive for them to change their own behavior?
That's actually a very good question, and I recognize that this is the first time we are asked this question. What is the incentive for the citizen to change their attitudes? It's something that we really need to think about. It's a way to Spanish way. I'm answering you with another question, you know? No, I think that what we are trying to do is trying to engage patients, making it easier for them to connect with the system, to feel part of the system. So preventing them from feeling that it's very complicated to shift or to go from the primary care to the hospital, that there are a lot of steps, a lot of barriers to be overcome. So the incentive for them is to feel more confident around the care that they are getting, to feel more engaged as a part of the system, and to feel that they are someone. They are not simply a number. They are someone. They are a person, and the doctor and the nurse, they know who they are. And we are taking care of you as a citizen, and we want you to stay as healthy as possible. So use the healthcare portal, be compliant with your treatment, be responsible with your eating habits, do not smoke, things like that. It's important. So it takes a while, of course. It's about changing the mindsets of people, but I think that's the idea. I mean, making them feel like they are in charge.
Yeah,
Yes,
but
John, yes.
on the other hand, this is more a public health problem. As long as you don't encourage people to go on bike to their work, for instance, instead of going by car, and as long as you have fast food next to a secondary school, as long as you allow smoking everywhere, etc. So it's more public health. Don't think that the healthcare system, despite the fact that you're doing very well things, very nice things, that a healthcare system can do this on their own. It's a societal problem. But that's the same in Canada, I assume. Yeah.
I might, Paul, I might just add one small perspective, which is that, and I think when you're using outcomes data in particular, and I do think that, back to this earlier question, that from a policy perspective, I think one of the greatest things you can actually do is to set the outcomes we measure, and then, as you said, one size doesn't fit all. But outcomes, I think actually there is a consensus around what you can do, and then that should naturally stimulate people to organise themselves accordingly. And I don't think we can, from a professional perspective, we should forget that I firmly believe that most professionals are in this game to improve outcomes. And of course, what you want to be able to see is how people are doing. And I think as soon as people do start to see that they're not doing that well, naturally the question comes why, and how can we make that better? And I think exactly the same, which goes to the organisation point. It stimulates the question, how should we organise in order to make ourselves better? But it's exactly the same, I think, whether you're talking about a person that isn't yet a patient, or however you want to define patient. Of course, we should all be involved in the care that we're engaged with. And there was a very nice article in the British Medical Journal not that long ago looking at Sweden and their rheumatoid arthritis work. And when people are engaged with seeing how they're doing, what their outcomes are, how they can work to improve their outcomes, and how they're doing in comparison to other people of a similar case mix, I think is very motivational in terms of getting them also working towards taking responsibility for their own health, their own care, and therefore, by the very nature of that, their own results.
Yes, I'd point you to Creating Public Value by Mark Moore, a Harvard professor who in 1993 produced a book which was simply about exactly what you said, about how you engage the public in co-production of value. Final question, anyone else with a question?
I have another question for Santiago, I'm afraid. Sorry, I'm Sally Lewis from Nairn Bevan Health Board in South Wales, and like Paul, I was struck by the similarities between our system, and somehow I knew you were a GP. I'm a GP too.
For the best of humankind, I am not a doctor.
Oh, you're not? I thought you said you were. Sorry. We have an integrated system as well, but there's one key difference, and that is that our general practitioners retain independent contractor status. And I think that model is now outmoded and is actually actively acting as a barrier towards service integration in many ways. One of the reasons that is frequently cited by my colleagues who would disagree with me is that if we lose the independent contractor model, we will lose some efficiency in the system. And I wondered what your view was on that, bearing in mind what you've seen in your own system.
It's a very interesting question. Thank you. We have to go back in time to 2003, when the integration was about to happen. professionals at both sides, and the hospital and primary care, they felt threatened. And what's on me? What's for me on this change? What's for me in this new scenario? So there was a lot of doubts, and people felt like I don't know what's going to happen. It is about letting them agree together what is best for the system, for the citizen. What we did was to empower our professionals, doctors from the hospital and primary care, and sit around a table and talk and discuss medicine. Forget about euros, forget about other things. Talk about processes, talk about healthcare, talk about what you think is best for the citizen, and agree on that. Try to build on consensus about what type of healthcare delivery model you want in place here. It's listening to them and let them feel, that they are leading. They are the actual leaders for change. Okay, so it's about. That's not maybe the case here in England, but in Spain, the primary care was, like the poor brother. Okay, everything was hospital oriented, and the best paid professionals were in the hospital, and best technology was in the hospital and everything. So they oh my God, now the hospital is going to take over us, so we are finished. And that was exactly the contrary. I mean, it's about empowering GPs, letting them feel that they are the owner of the patient, they are the owner of the process, and they decide, and why not expanding the service portfolio. Some GPs wanted to start doing some minor surgery, for instance, or doing rotations in the A&E department in the hospital, or even dealing with the internal medicine doctors. So there is, for instance, there is a link. There is an internal medical doctor who acts as a link with every GP premise. So it's about bridging the gap between the two big providers and making them feel like they are part of something bigger. They are part of a big system, Maybe it sounds a little bit philosophical, but that's the way it is. I mean, it's about listening to them and empowering them.
Okay, we've got 2 minutes for final question, if there's one in the room. Someone at the back there?
Jenny Field, Health Education England. I was impressed with, this afternoon was the first time I think that we talked about our staff and the power of the doctors. So I just wondered, how much should we integrate the learning about value in the medical curriculum so that they're not just learning about treating the patient, but the whole population health?
Yeah, well, I might start there, Paul, actually, if you don't mind. I've spent a lot of time thinking about that, actually, and I think it is partly due to our roots out of the group at the Harvard System and the Karolinska Institute. And I think we are very keen and believe it's very important to do exactly as you say. And I can speak from a very personal perspective. I mean, you do not think, generally speaking, about this at medical school. You're focused on disease, generally speaking, and the treatment of disease, and how you do that, and of course understanding what leads to disease. So I believe, and we believe as an organisation, that it is essential to get this mindset into people. And what's more, I think when you look at what's happening in health systems, not just here but everywhere else, I think most people want to do this. I really believe, whether they're most senior people within hospitals and certainly most junior people, I think see the importance of this. And so I think it's extremely important, I would say, and I think now is the right time actually to try and get these approaches ingrained within medical curricula.
Okay, could I thank the panel then, please, for fantastic précis, and we are very grateful indeed. Thank you.